You are at the front line of life-saving medicine. From managing mechanical ventilation and advanced oxygen therapies to navigating complex critical illnesses, this is a field where precision and expertise define outcomes. To excel, you need more than knowledge. You need mastery in applying it under pressure when every second counts. Elevate your expertise. Apply for the fellowship in respiratory critical care. This program empowers you to master mechanical ventilation, advanced respiratory support, and critical care strategies for patients with the most complex conditions. This is not just another training, it's a transformative experience designed for ambitious professionals determined to redefine their practice and impact. Learn from world-renowned experts. Gain clinical insights, practical pearls, and the latest evidence, all accessible from wherever you are. Our curriculum is comprehensive, covering the full spectrum of respiratory and critical care, from invasive and non-invasive ventilation, ARDS, and sepsis management, to ECMO and advanced rescue therapies. You'll gain practical, actionable expertise. Engage in live, interactive sessions, present your toughest ICU cases, collaborate with peers across the globe who share your passion for saving lives. This is your chance to strengthen your expertise, expand your career horizons, and join a community dedicated to excellence in respiratory critical care. The future of respiratory critical care is here. Are you ready to lead it? Applications are now open. Visit our website to begin your journey today.
Hello, everyone, and welcome to our Respiratory Critical Care Fellowship webinar. We have a very special webinar today. And as you can see, we have very special guest speakers and also moderators. We have Dr. Muhammad Abdurrabbi Nabi, who is a consultant, both critical care and emergency medicine at Dammam, Eastern Province, Saudi Arabia. And we have Dr. Zahra Al-Dawood, who works with Dr. Muhammad in the same place, and she's the Deputy Program Director. And we have Dr. Yasser Tolba from King Faisal Specialty Hospital, and Dr. Hisham Faisal from Al Batain Hospital, also in Dammam. Here is our today's agenda. After this intro, we will listen to a fantastic lecture from Dr. Muhammad Abdurrabbi Nabi. Then we'll have a case-based discussion by Dr. Zahra Al-Dawood. Then Dr. Yasser Tolba and Dr. Hisham Faisal are going to moderate the session and try to answer the question and help our speaker to answer the inquiries as well. So again, our main guest speaker today is Dr. Muhammad Abdurrabbi Nabi, who is a critical care consultant at the Dammam Health Network. He's the chairperson of Critical Care Service Line at Eastern Health Cluster in Saudi Arabia. He completed his critical care medicine fellowship at University of Western Ontario, Canada, and also he did a teaching fellowship with the American College of Emergency Physicians. And his talk today is the main topic will be non-invasive ventilation, practical mastery from initiation to liberation. Then our second speaker is Dr. Zahra Dawood, who's going to give very interesting case-based discussion how to utilize, how to use and apply the non-invasive ventilation. Again, great speaker, Dr. Yasser Tolba from King Faisal Specialist Hospital and Research Center in Riyadh, and Dr. Hisham Faisal, consultant intensivist and head of cardiac surgery ICU and ECMO expert in Suaid al-Batin Cardiac Center in Dammam. Again, if you are interested to join our Respiratory Critical Care Fellowship, which is 1 year online fellowship program accredited by the American Association of Continuing Medical Education, we are going to start next Monday, June 15. And if you haven't joined yet, you can join and you can get 10% discount using the promo code of 10RCC for our today's attendees. Just housekeeping stuff here. If you have any questions or inquiries, type it in the QA box. All attendees should get certificate of attendance by next week. And if you would like not only to listen, but also to see the transcribed lecture on the screen, please go ahead and activate the show caption option, enable the show caption option. Again, we are not here to tell you the fact, but we are training your mind to think better because we are either need to think or we are going to think. And with that, I'm going to stop sharing my screen and we'll let Dr. Muhammad Abdurrabbi Nabi share his screen and start his fantastic presentation about non-invasive ventilation from application to liberation.
Assalamu alaikum, Masa al-Khair jami'an. Hello, welcome everyone. So today's session is about reviewing non-invasive ventilation basics. It's about decision making under pressure. When do you start? When do you stop? And how to liberate people from non-invasive ventilation. Now, to start with, I want this slide to be like the main slide of the whole presentation. NIV is a trial with a deadline, and I will keep repeating this sentence all through my lecture. So NIV is a trial with a deadline. We know that NIV does decrease intubation indications. This is proven in at least 2 of the main diseases that we use NIV for, like COPD and cardiogenic pulmonary edema. We know that NIV is time sensitive, which means if you initiate it early, you get better outcomes. If you delay, you eventually need to intubate your patient. But we also know that NIV success appears very early, success or failure, obviously. So within 1 to 2 hours, you will have to have a decision, and hence the name trial with a deadline. And the risk, obviously, is delaying the intubation. We will see how this risk potentiates as we go through the slides, inshallah. So after reviewing evidence, we know that the high-yield indications include 1, COPD exacerbation. So COPD exacerbation is your major indication based on a myriad of evidence that's already published. It is the strongest evidence that it reduces intubation, it improves mortality, and it decreases ICU stay. While in pulmonary edema, we know that using non-invasive ventilation, whether CPAP or BiPAP, actually improves symptoms of acute respiratory distress very rapidly. In at least like 1 out of 5 patients that you apply it for. Now, we also have other indications. These are the black and white indications, but there are other indications. For example, hypoxemic patients, hypoxemic respiratory failure, but this requires maybe careful patient selection, and we will talk about it in the next slide. Remember, there's one more indication of BiPAP, so it's not just an acute emergency. Sometimes BiPAP or non-invasive ventilation is prophylactic, and we use it for high-risk patients post-extubation. But the evidence clearly shows that if you use it, if you decide on it a priori, which means for a patient who's high risk to be, you believe that the patient has high risk for extubation failure, then you decide to institute non-invasive ventilation prophylactically post-extubation before the patient fails. That improves outcome. But obviously, if you, the other way around, if you extubate some high-risk patient, the patient fails, and then you use non-invasive ventilation as rescue therapy, it only serves to delay reintubation. Now, back to the gray zone patients. We know COPD and cardiogenic pulmonary edema, but what about pneumonia, for example? We believe that non-invasive ventilation also has room in hypoxemic failure patients, for example, pneumonia patients, although it has a high failure rate, but in some selected patient, it might have short-term benefit in terms of stabilizing a patient until you actually administer other management modalities. But you have to monitor very intensely, and you have to have a low intubation threshold in pneumonia patients, simply because if you think of an IV as a trial with a deadline, then it has to be a trial until definitive therapy works. And antimicrobials will take generally 2 to 3 days. Pneumonia patients in general will, they almost always worsen before they improve. So instead of putting non-invasive ventilation for 3 days with all its complications, probably such patients might do better with intubation, but it's always worth a trial if the patient has mild hypoxemia. Now, talking about hypoxemia, make us think of mild ARDS. And mild ARDS, the evidence is more limited, but we have used it extensively during COVID season. And as you remember, in the COVID season, we used helmets. We kind of preferred the helmet for ARDS patients based on previous evidence many years before the COVID season. But during the COVID season, there's another landmark trial which was published by Dr. Yasin, Professor Yasin Arabi. And basically it shows that helmet, it's called the helmet COVID. And basically helmet probably does not improve mortality. At least it wasn't shown to improve mortality, but at least it might improve patient comfort. Having said that, my personal experience, I've seen people who also get claustrophobic with the helmet. You can imagine the feeling. The one caveat to notice in mild ARDS patients is the patient's self-inflicted lung injury, PSILI. This is a real problem. And I am at the bedside, I can't say it enough. At the bedside, it has been ignored way more times than I would like. And basically, someone on non-invasive ventilation then suddenly worsens, gets intubated, and then the chest X-ray shows a pneumothorax. And people think it's because of the intubation and high vent pressures, rather than it's probably pre-existing. It's probably the reason why you intubated. Such patients, for example, might have the whole issue with the patient self-inflicted is that the patient is using accessory muscles during the non-invasive ventilation. The patient is still in distress despite the positive pressure that you're instilling. So if the patient is creating negative pressure while you are giving positive pressure, then this creates a high transpleural pressure, which contributes to barotrauma, pneumothorax, and patient self-inflicted lung injury. The third gray zone is immunocompromised patients, and historically, people shy away from intubation of such patients. So BiPAP might be a good option. High-flow nasal cannula might also be a good option, specifically if someone is having large secretions, being more comfortable and humidified and warm. So know your patient, but this is one option in your armamentarium. It's probably not the best option for all patients, but it's one option. But for non-invasive ventilation safety, you never forget contraindications. So yes, I want to use it for COPD or cardiogenic pulmonary edema, and sometimes for hypoxemic failure. But always remember, if a patient is in cardiac arrest, obviously they should get an ambu bag, maybe an ET tube, and chest compressions. If a patient has no airway protection, large secretions, poor cough, then such patient requires airway protection rather than BiPAP. Uncooperative and combative patients might be, it's a two-edged sword. So for severe combative patients, definitely they will never accept BiPAP. But for mild combativeness or mild agitation, remember, one, this agitation could actually be related to the hypoxemia and hypercapnia. So maybe alleviating this could actually decrease the agitation and improve the patient comfort. Two, agitation might be related to the sensation of distress. And once you alleviate distress and work of breathing, that also might actually improve agitation. Third, there is potential for sedation. And although sedation could be a problem in some patients in terms of respiratory center depression, but there has been a published study recently about using dexmedetomidine, otherwise known as Precedex. I know the trade name is a lot easier to pronounce. So Precedex might actually improve patient tolerance to BiPAP if the patient is mildly agitated, but of course, always pay attention to patient's respiratory drive. A patient with a life-threatening GI bleed needs a tube and an EGD. They don't get a BiPAP. BiPAP could be a killer for such patient. Now, we did talk about excessive secretions, so this is a relative contraindication. You can proceed with caution, but make sure the patient can clear secretions. Such patient might require frequent BiPAP breaks for suctioning and chest physiotherapy. Facial or GI surgery is not an absolute contraindication unless it precludes the application of the mask. But if the facial, for example, is up here, or it does not preclude the application of the mask, then it should be fine as well. Now, this is a given, CPAP versus BiPAP. I'm pretty sure everyone knows what that means, single pressure versus two pressures. The thing is, we should think of CPAP as an oxygenation weapon. So basically, CPAP causes alveolar recruitment, increases the functional residual capacity, which means it improves oxygen diffusion. So it's best for cardiogenic pulmonary edema or obstructive sleep apnea patients, which is not an emergency, not in our situation. Now, for BiPAP, because it has the other pressure, the IPAP, then we mostly use it for ventilation to drive tidal volumes and minute volume to improve CO2 buildup. And it also helps with oxygenation because it has CPAP built in. So we use it mainly for type 2 respiratory failure patients like COPDs. Now, the physiology is easy. Pressure support is IPAP minus EPAP, or IPAP above EPAP, depending on your machine. But basically, instead of calling it pressure support, you can call it driving pressure, just like the invasive mechanical ventilation term, which is plateau minus PEEP. Well, right here, it could be IPAP minus EPAP, or IPAP above EPAP, depending on your machine. So basically, the main reason why we use this driving pressure, the difference between IPAP and EPAP, is to drive tidal volumes, minute ventilation, and CO2 washout. Obviously, this also decreases work of breathing. Now, this is the difference in IPAP and EPAP. EPAP by itself is oxygenation weapon, while the difference between IPAP and EPAP is your ventilation weapon. Now, before we start talking about vent parameters, let's talk about interface. And interface selection is probably, selection and adjustment is probably the most important step of non-invasive ventilation. And we as clinicians, we generally forget that. We generally leave that to our colleague, the RT, who knows exactly what to do. But obviously, you as a team leader, you should know you should also know what's going on with your patient. So we know that there's a full face mask, and this is in 90% of the time, this is what we will use in the ICU, maybe more than 90%. It's the most common. It tolerates mouth breathers, patients who are agitated, usually breathe from their mouth, or patients who have a blocked nose or for whatever reason, or patients who have their mouths open all the time. So that's why we prefer it over nasal BiPAP, although nasal CPAP is the preferred of choice for obstructive sleep apnea at home, because it allows people to talk, to eat while on this BiPAP. It's a lot more comfortable during sleep. And then the helmet BiPAP, which might have superior comfort, might reduce patient self-inflicted lung injury in ARDS patients. Now, once you select your interface, then how would you assure patient comfort? One, you have to hold the mask yourself, not strap the patient. So the first step is not putting the straps and securing them so tightly, because that will surely make the patient claustrophobic and fail the first trial of non-invasive. So, and don't just strap and leave. You'll have to hold the mask by yourself. Maybe even ask the patient, if the patient is cooperative enough and not in severe distress, to hold the mask by themselves and then approach to their face. طبعا, while you're doing this, you're narrating your steps. You're like a voiceover in a movie. You know, this will feel like wind blowing in your face. Breathe normally. I'm right here. If you feel distress, I can easily remove it. Play with the machine, make them, ask them to cooperate with the machine as opposed to pushing against the machine. Once they get the hang of it, it makes a lot easier for them to be comfortable on the non-invasive. And of course, start low. You don't go an IPAP of 20 and expect people to tolerate it all of a sudden. It's a huge amount of pressure. I remember as a fellow, I tried applying BiPAP on myself, and I felt suffocated, seriously suffocated. I could not tolerate it more than 60 seconds. I had to take it out. So, so start low and then go slow on your escalation. So I'd start with an IPAP of 8 or 10 and then escalate really slowly by increments of 2. Now, once you apply the mask and you make sure that the patient is comfortable, then you strap the mask and then make sure there is no leak. So control mask leak, the number 2 problem for non-invasive ventilation failure. It's not the settings, it's the interface. So you have to identify the leak, and it's easy to identify if you look at air blowing into the eyes, moving the eyelashes, or putting your hands around, especially around the nasal bridge, which is the most common area of leakage. But also check at the cheeks, especially in people who with wasted muscles or no teeth, edentulous patients, or maybe down the chin, especially in patients with a large beard. Now, some leaks up to 30 liters per minute are acceptable if the machine will compensate nicely. Otherwise, more than 30 liters might actually cause trouble. The thing is, if the leak is too high, the machine will compensate even more, which creates even more leak, which makes the patients more uncomfortable because of the blowing air. You're basically ventilating the room and not the patient, and eventually the patient fails, and you're looking at settings. So how do you know the straps are tight enough but not too tight? By applying the 2-finger strap rule. So basically, you stick your fingers underneath the straps and make sure you can only fit 2 fingers. If you can't fit any fingers, that's too tight. The patient will have pressure ulcers in no time. But if you can fit your whole hand, obviously that's too loose, and that's why you might have leak. And you have to recheck continuously. Patients move, patients get fed, patients get a break. So you have to recheck for leak continuously and reassess every time there's a beep or every time the patient seems to be distressed or the nurse summons you. Now, once you make sure the interface is well and good, then you move on to initial settings. We generally start low, as we mentioned, with an IPAP of 8 to 10, with an EPAP of 4 to 5, and then you escalate by 2, depending on your feedback from the patient. You generally start with an FiO2 of 100%, but you quickly wean down for the desired pulse oximetry, and we know that we do not like over-oxygenation. Remember, hypoxemia per se is not as dangerous as hyperoxemia. So almost, we've seen that in COVID. People do not die of hypoxemia. They almost always die of other problems, like ventilatory pressures and barotrauma and difficult to ventilate. But in hyperoxemia, you know that you expose your patient to oxidative stresses and lung injury due to the oxidative stress. And for COPD, it's even more so. So a goal of 93 to 94% for regular patient and 88% for your COPD patient is appropriate. And sometimes you might need a backup rate. You might see your senior RT putting people on pressure control with the non-invasive ventilation, which means if the patient has any apnea period, the machine will give them a breath. So it becomes more like an assist control rather than pressure support. BiPAP in general behaves like pressure support unless you put an assistance, which is a backup rate. And this could be useful in patients with central apnea, for example, syndromes. So once you put the initial settings, how would you titrate? Obviously, you have to identify hypoxia according to the targets that we mentioned. And once you do, your first parameter to titrate is EPAP. As we said, EPAP is equivalent to PEEP or CPAP in invasive ventilation. And you escalate by steps of 2 in general, 2 to 3, عشان to avoid numbers that you don't like. Nobody puts a PEEP of 7. Almost always we go from 5 to 8 and then from 8 to 10 for some reason, but obviously that's not a clinical reason. So we mentioned that EPAP recruits alveoli, improves oxygenation. We prefer titrating EPAP than titrating FiO2. As we said, EPAP is protective, but FiO2 could be injurious. So we titrate EPAP, and if it doesn't work, then we titrate FiO2. And if you come to a ventilated patient with a pulse oximetry of 100%, then something is wrong. That's too much oxygen. Okay. Now, how would you titrate for hypercapnia? Again, you increase IPAP by increments of 2, aiming for a normalized pH. So remember, in COPDers, you don't aim for a normal CO2, you aim for a normal pH. Your goal is pH. So in general, if you just aim for a normal pH, then you will avoid over-normalizing people who might be chronic CO2 retainers, which you did not know about, because you don't know baseline CO2 in many of your patients. And even non-COPDers might be CO2 retainers, for example, chronic obstructive sleep apneas or obesity hyperventilation syndromes. So always aim for a pH rather than CO2 normalization. And you can aim by increasing driving pressure, IPAP steps of 2. Sometimes if the patient is not hypoxemic, they can tolerate a lower EPAP, then EPAP can be lowered. For example, you lower EPAP to 4 to widen the gap between IPAP and EPAP and produce better minute ventilation. But you have to know your ceiling. So for IPAP, we know that COPD studies the earlier COPD studies looked at IPAP of 20 as your maximum IPAP. And the reason is basically once IPAP is above 20, it does not confer any additional benefit, and it might actually open up the esophageal sphincter and cause gastric insufflation. Now, you don't just titrate for oxygenation and CO2 ventilation, you also titrate for patient distress, and this probably is much more acute than looking at CO2 clearance. So patient distress should be alleviated within the next 10 minutes or so. This is the critical 10 minutes that you stand next to your patient and make sure that non-invasive ventilation is working. And of course, if a patient remains in distress or patient improves and then they call you back because the patient is distressed, then you have to look at a few steps. First and foremost, you look at the interface. As we said, it's probably the #1 problem failure. So look at the interface, look for leakage, look for too tight, make sure you refit the mask. Maybe the patient needs a mask break for a few minutes. Maybe the patient needs to cough to clear out some sputum. So always check interface. Next would be synchrony. Synchrony is underappreciated in non-invasive. We always look at it for invasive. But for non-invasive, because patients move, it might be too hard to look at يعني the ventilator curves and judge asynchrony. But you can easily judge by looking at the patient. If the patient seems to be taking a breath, trying to take a breath with accessory muscles, but the machine is not giving them, then this is missed trigger, and maybe you need to increase sensitivity. The other way around is auto-triggering. For example, if there is a massive leak, the machine might auto-trigger, and then you might need to fix the mask and maybe even reduce sensitivity to avoid auto-triggering. Also, remember the inspiratory rise time. Now, this is RT arena, and I don't pretend to be the expert, but your senior RTs, I'm pretty sure if you ask them at the bedside, they will tell you about the rise time and how it affects patient comfort. If the rise time is too fast, it means the inspiratory rise time, the initial phase of the inspiratory, it means the patient is feeling a fast blowing air in their face, and they feel discomfortable and distressed. The other way around, if the rise time is too slow, then the patient feels under supported, and then he starts يعني اللي هو the patient self-inflicted lung injury pathway. So always match the patient's breathing pattern. Look at your patient and judge. And then you look at settings. Once you finish all of these, then you look at the ventilatory settings. Maybe the patient needs a higher IPAP. The patient needs some more support. يعني, and last, obviously, if the patient is still distressed despite what you have just done, then this is an IV failure. Please go ahead and intubate. Don't wait for miracles. So you've put NIV. How do you know the NIV has succeeded? Obviously, all of the above. So we mentioned RR, and RR should start falling. If a patient is tachypnic, the RR should start falling, at least within the next 10 minutes. Let's say by 30 minutes, you should have an RR, which is back to baseline. You should have the distress alleviated, يعني accessory muscle use, work of breathing. Clearly, the patient seems to be settling down. You can touch the sternocleidomastoids and see if they're still firing. You can check the patient's anxiety يعني picture. How does the patient face look like? More relaxed now, breathing more comfortably. But remember, there's a trap, which I will mention later. So patient settling down does not equal patient getting obtunded. These are two different categories, and you have to differentiate because one of them can look like the other. Now, the hard objective evidence is basically pH, as I said, in BiPAP or oxygenation in CPAP. And of course, the opposite goes for NIV failure. RR not improving, pH the same or even worsening, patients still getting more agitated or distressed, oxygenation not improving, CO2 not improving, or patient becoming altered consciousness. And this is the trap, as I said. Settling down is not the same as being obtunded. Now, the decision points are generally first, the first 10 minutes when you're still standing next to your patient. As we said, you don't strap the patient and leave. So the first 10 minutes, this is your first checkpoint. And then you leave and come back at 30 minutes, the second checkpoint. Does the patient look calmer? As I said, less distress, RR trending down, oxygenation is looking good. By 1 hour, you do your first blood gas checkpoint, basically looking for pH, as I said, improvement, and maybe CO2 trending down. And then 90 to 120 minutes, the 2-hour rule, is basically your hard stop. Either the patient is improving or he's not. There's no longer than 2 hours. If the patient looks good at 2 hours, you're fine. You can continue your trial until the cause is alleviated. If the patient does not look good at any time, GCS drops, patient become apneic, hemodynamic collapse because of the positive pressure, patient vomits on BiPAP, cardiac arrest, obviously, then you obviously stop NIV and intubate. And remember, يعني stopping at any time will be more like an elective intubation, which is always safer than a crash intubation. Let's talk a bit about mask issues. So we spoke about excessive leaks, and we mentioned this in details. We forgot to mention trying different sizes of full face mask, يعني in addition to refitting the mask and checking the strap. But remember, mask can also cause skin injury. I've seen people getting ulcers at the bridge of their nose by 2 hours of applying the mask. So this could be pretty severe very early, um, especially with high vent pressures. So apply prophylactic dressing from the get-go. Before you put the mask, just put the prophylactic dressing. It doesn't hurt anyone. And then maybe you need to rotate interface if needed. Remember the claustrophobia. This is a mask problem that can actually fail your NIV even if your settings are grand. So always gradual and narrate and everything. Secretions and airway issues. I'm sure you've heard your RTs mention before, for example, that patient cannot clear secretions, we cannot apply NIV, that's a contraindication. As we said, yes, this is a cautious relative contraindication, but if the patient cannot clear secretions, يعني poor cough, then this is an absolute contraindication. But if the patient can clear secretion, then maybe adding frequent mask breaks, adding chest physiotherapy, maybe suction as needed, might actually prevent intubation. We know that the closed system of the BiPAP يعني prevents drainage of the secretions and weakens the cough. Gastric insufflation is another problem of another airway problem of NIV. Specifically, if the IPAP is too high, 20 or above, then you expect gastric insufflation. And this is a problem because it can cause distension, it can cause discomfort. Patient might be distressed because of the abdomen and not the chest. So always check the abdomen. And if it's distended, tympanic to percussion, then maybe reduce the IPAP as much as possible, يعني the lowest effective IPAP. And maybe if the patient needs a high IPAP, maybe put an NG tube, a small bore NG tube with free drainage to decompress the stomach. And of course, gastric insufflation might induce vomiting and aspiration. So, and if the patient vomits, there's nowhere else that the vomitus will go except the airways. So always be very careful. If the patient feels nauseated, give them antiemetic before applying the NIV. If the patient is full stomach, that increases the risk. In the acute phase, do not feed people because there is risk of intubation. So do not feed people in the acute phase. But once it is in the chronic phase, يعني after 6 hours, patient looks good, comfortable, you're just giving them a mask break, then you might be able to feed them. Obviously, if the patient vomits, remove, suction, position the patient in recovery position, and then plan for intubation. So if the patient fails and you've decided to intubate, then prepare. Always prepare. So don't rush the intubation process. That's why you need to decide early as opposed to crash intubation. So call your team, get your RT on board, your nurse, prepare your medications, your RSI box. Pre-oxygenate BiPAP is a beautiful machine for pre-oxygenation. So just bump up the FiO2 to 100%, keep the BiPAP for pre-oxygenation, unless the patient is distressed. But the BiPAP would probably confer the best pre-oxygenation device. And then prepare your medications and intubate in a controlled setting. So this would be more like a semi-elective intubation as opposed to the crash intubation. So always do not rush. So if you feel that the cause is improved, for example, in pulmonary edema, you applied CPAP or BiPAP, and then you gave the patient Lasix, the patient peed a bucket, or you started nitroglycerin infusion and the patient's blood pressure, يعني the afterload has improved, then maybe it's time to wean CPAP. Patient cause has improved. You will also notice that the patient has less distress, stable blood gases, maybe lower oxygen, يعني FiO2 needs. So such patients يعني would do best in 4 hours to disconnect the CPAP and BiPAP and reassess the patient. Obviously, if someone is still using accessory muscles with high work of breathing or unstable blood gases, then he's not ready for weaning. Now, for patients who have been on BiPAP for some time, let's say for the past 24 hours on and off, but now they're looking better and they're improving gradually, specifically COPD patients with chest infection. Such patients, the weaning strategy aims at reducing the NIV time, for example, from 6 hours at a time to 4 hours or to 2 hours, and increasing the mask off time. So you're basically giving the patient a longer break, 1 hour, 2 hours, 3 hours, 4 hours. You're basically testing the patient independence. While you're doing this, during the mask off period, you're monitoring for signs of failure. You're looking at RR, you're looking at respiratory effort, mental status. Maybe you do an ABG, you don't have to, but you can do an ABG during the mask off period, maybe 2 hours or 4 hours after taking off the mask, but only if the patient seems to have a change in respiratory status. If the patient seems to be doing very well, even the ABG you might forego. Obviously, pulse oximetry is never enough. And if the patient has any signs of failure, then you need to resume NIV without delay. Now, sometimes you might elect to step down NIV to high flow nasal cannula if a patient is high risk for failure. Just like weaning extubation to non-invasive, you can wean non-invasive to high flow nasal cannula in patients where you suspect highly suspicion of failure. So the key message is NIV is a trial with a deadline. Early response determines the outcome, 1 to 2 hours, and always assess within this time frame, and do not delay intubation if the patient needs to. Controlled intubation is safe, crash intubation is not safe. And that leaves the floor for any questions.
That's a great presentation, Dr. Muhammad, as usual. Very thoughtful, very informative lecture. And before we open the session for the question and answer, we have a short video describing our fellowship that is going to start on Monday. We'll show you how the fellowship works on the platform. Then Dr. Zahra is going to give her case-based discussion. Then we'll open the session for discussion. Hello, everyone, and welcome to our Respiratory Critical Care Fellowship that is going to start on Monday, June 15. And all of you will get username and password. You're going to receive an email with your credential upon completion of your registration and application. Then every week you will have new materials in this smart platform, starting from week 1, week 2, week 3, for 16 weeks. Then you will have the chance to navigate through these high-quality educational materials, starting from introduction about this week. And let us hear this introduction for week 1 of the fellowship. Welcome our Respiratory Critical Care Fellows, and we are starting our fellowship with Module 1, and the topic of this week 1 of Module 1 is Anatomy and Physiology, and we are not teaching you the basic science. We are trying to give you the applied anatomy and physiology to improve your clinical practice and your patient's outcome. With this 1-year online fellowship program, you need to learn from each single MCQs article, from the lecture, from clinical case scenarios, and also from the journal club. And each question, you need to spend more time. After you submit your tasks and assignments, you'll get your automated score, then you will get explanations of each answer. Try to learn from your mistakes. Try to read the explanation very carefully, because these questions are not to judge you or to assess or evaluate you. It's to educate you. These are all educational materials. We are looking to your educational growth and your learning curve. And we are trying to find our limitation and our strength. So try to find who you are, what you are doing, what's your strength, how to improve your practice and your patient's outcome. Here is our first module, which is 16 weeks, so 4 months. We start with applied anatomy physiology, then pathophysiology of respiratory failure, then critical care monitoring. Start with pulse oximetry, capnography, hemodynamics. Then each 4th week we'll have a webinar for close to 1 hour, 1 hour 15 minutes. Then you will have a week focusing on blood gases, then respiratory imaging, starting from chest X-ray, CT, then going to point of care ultrasound, again followed by a webinar. Then we'll talk about respiratory infection from CAB to HEP, VEP, viral pneumonitis to fungal infection, candidemia, then acute diffuse interstitial lung disease, followed by a webinar. And there will be 3 weeks of exit exams. You need to get 60% of each week to be able to graduate and to finish this module and to go to the next module. Again, if you have any questions or concerns, please feel free to reach out to me. You can email me or you can send me WhatsApp message, and I'll be very happy. So after you finish this introduction, every week you will have new lecture, about 1 hour lecture, and you have 24/7 access to watch.
Expel air across my vocal cords, and I manipulate them in addition to my mouth, tongue, etc. You're going to hear speech. So when it comes to the breakdown of what's in the respiratory tract, we can look at it at the upper respiratory tract and then the lower respiratory tract. So the upper respiratory tract is going to include everything from the nose down to the throat. And so if we start with our first slide here, we're going to begin with the external nares. And that is a fancy term for nostrils. So these are my external nares. The hole that actually leads into that opening, into your respiratory tract, we can call the vestibule. And vestibule basically means like entrance or doorway. And there are other parts of the body where the term vestibule is used. So here, the actual holes in my nostrils, that entrance is called the vestibule. The nasal septum, septum are used in other parts of the body as well, like there's a septum in your heart that separates, for instance, the 2 ventricles from each other. And in this case, the nasal septum is separating the 2 sides of your nasal cavity.
So after you listen to this lecture in the platform, you will have clinical-based MCQs. So we'll give you a story of a patient. Here again, we are trying to focus on anatomy, applied anatomy and physiology. So we'll ask you some questions after you will watch the recorded lecture, and you are going to be challenged with some questions. I'm going here just for the sake of the time to choose random answers to let you know exactly what will happen after I will submit this task. So let me submit the quiz here, and what I'm going to receive is an automated score in the platform and also in my email. So I got 20% because I answered randomly. And most importantly, I'm going to see the correct answers and the explanation of each answer with detailed explanation, with references, up-to-date references, as you can see here, 2025, 2026 references. So very up-to-date information. This is what you will get every week. You will have recorded lecture, and you will have MCQs. Then you will have article to read either online or offline. You can download it from here and read it. After you finish reading the article, you can go ahead and try to answer this Journal Club MCQs. Usually you will have 10 MCQs for the lecture and 10 MCQs for the Journal Club, then another 10 MCQs for the clinical case scenarios. So let's just randomly, try to answer some of these questions and submit the quiz. And what will happen also is I'm going to receive an score. I got 0 this time, so unfortunate. And I'm going also to receive the explanation of each answer. These questions are not to test you or to evaluate or to judge you, but to educate and to let you to learn from your mistakes. So every week you'll have lecture about 1 hour, then clinical-based MCQs, then article to read, then MCQs on the article, then clinical case scenarios as this clinical case scenarios. So let us do clinical case scenario 2. So usually you'll have 2 or 3 clinical case scenarios, and each will have at least 4 or 5 questions. So this is a detailed case. We'll give you the mechanical ventilation settings, maybe APG results, and I'm going also to submit some answers here and to see exactly what will happen after this. Let's do submit quiz. Then I'm going also to receive my score and explanation of each question. So this, again, I'm lucky this time, I got 50% randomly. Then I'm going to read the detailed explanation of these questions. So just imagine for 52 weeks all over the year, you will have every week new materials, and every 4th week you will have a live webinar to interact with the board members, with the instructors and tutors. So this is very high quality educational program, very well structured with international expertise from all over the world. It's accredited by the American Association of Continuing Clinical Education. If you haven't joined yet, please feel free to join us. We are starting next Monday. With that, I wish you all good luck.
Thank you very much, Professor Amr. It's now my pleasure to introduce Dr. Zahra Dawood, who's an intensivist from the MAM Health Network. Dr. Zahra is the Deputy Program Director for the Saudi Board of Critical Care Medicine in the Eastern Health Cluster. And she's a brilliant intensivist that I know up close and personal. So please welcome Dr. Zahra.
A 74-year-old male with severe COPD, presented with severe dyspnea the past 2 days. He's been using accessory muscles. He's unable to complete sentences, and his vitals were as follows. He was tachycardic, tachypneic. He was desaturating, so he was kept on a 5-liter nasal cannula, and the saturation was 88. Blood gas showed respiratory acidosis, 7.26, with a CO2 of 72. On examination, our patient was alert, conscious, however, he was fatigued. Auscultation was significant for prolonged expiration and diffuse bilateral air entry bilaterally. So he was kept on NIV with an initial setting of 12/5. And after almost 30 minutes of NIV initiation, our patient remained tachypneic. He's still using accessory muscles. And you've also noticed that the expiration appeared shortened, and the patient seems to attempt exhalation while the ventilator is still delivering respiratory flow. At that moment, there was no major leak noted. So what is the most appropriate next step? Option A, increase IPAP to 18. Option B, increase EPAP to 8. C, increase ventilator. Excuse me. Increase ventilator cycling threshold to allow earlier termination of inspiration. And the last option is to increase the backup rate to overcome such issue. So think about it for 5 to 7 seconds before you make your choice. And then we will move on to the next slide where the answers are stated with the explanation. So can we see the bar result?
Yeah.
If it's present.
Okay. Yes, Dr. Zahra.
Can we see the bar result? Are we showing?
No, there is no poll. Just go ahead and keep
Sure.
going.
So the correct answer is C. So increase ventilator cycling threshold to allow earlier termination of inspiration. So let's take it step by step. So basically, the scenario describes late cycling, which is a form of cycling asynchrony, where the ventilator basically continues inspiration beyond the patient's neural inspiratory time. So the most appropriate intervention to or to increase the cycling threshold. So if let's for instance 25%, so that basically means that the ventilator waits until the flow falls to 25% of the peak flow prior ending inspiration. So if you're aiming for a shorter cycle, the threshold should be higher, say 50%, 70%, and so on. And hence that would allow the ventilator to terminate the inspiration earlier. And طبعا that would result in better match of the patient respiratory pattern. طبعا the clinical significance of such asynchrony that should be focused on, because in COPD patient, let's say if that went unnoticed, then will lead just to a further prolongation of the inspiratory time, which will basically will be at the expense of the expiratory time. It will compromise the time for exhalation, which will lead to worsening dynamic hyperinflation, auto-beeping, and further distress. And then you'd end up all failure of NIV trial. So the bottom line is to increase cycling threshold, and that would allow the ventilator to terminate inspiration sooner, and hence correction of delayed cycling. Now, the remaining options were incorrect, as in option A, increase IPAP would improve the tidal volume, yes. However, that would worsen the hyperinflation and would prolong the inspiratory flow time further, aggravating the asynchrony. Option B, increasing EPAB, yes, this could help with intrinsic PEEP, but that does not address the timing of the inspiration. Option D, increasing the backup rate, again, that does not address the inspiratory timing. So this will not help with such asynchrony. So the bottom line of this question is that not all NIV problems are pressure related. Many of those issues are actually time related. So the next question is that our patient was reassessed after an hour, and our patient was showing intermittent and effective inspiratory efforts that do not trigger the ventilator. And those events were more pronounced during the period of fatigue. At that moment, there was no obvious leak or disconnection noted. So, what is the most likely underlying mechanism? Is it inadequate trigger sensitivity, or development of intrinsic PEEP due to dynamic hyperinflation, or excessive oxygen delivery suppresses the respiratory drive, or excess high IPAP leading to over-assistance? Let's pause for a few seconds. We'll need to think about it for a few seconds. So the correct answer is B, which is basically the development of intrinsic PEEP due to dynamic hyperinflation. So our scenario basically describes trigger desynchrony, specifically ineffective trigger. Our patient was attempting triggers, but his efforts were not sufficient to generate negative pressure to trigger the ventilator. طبعا the main contribution to that was auto beep, because the presence of auto beep creates a threshold load, basically an extra load for the patient that must be overcome first prior generating sufficient negative pressure. And on that, the efforts will be more pronounced during the periods of fatigue even. The remaining options were incorrect, as in option A, trigger sensitivity. yes, it can help adjusting such issue, but this is not the underlying mechanism that dominates such issue. So adjusting trigger sensitivity specifically will not solve it. Excess oxygen excess oxygen does not directly suppresses the respiratory drive to the extent where a missed trigger would develop, and it's not the underlying mechanism. And so, as in high IBAP, this could affect cycling, yes, but that does not alter the triggering mechanism. So the third question, which of the following adjustment is most appropriate to overcome auto-beeping? So option A, increase IBAP to further augment the tidal volume. B, increase EBAP to counterbalance the intrinsic beep. C, decrease of IO2 to stimulate the respiratory drive. D, administer sedation to get the tolerance in a better shape. So the correct answer is B, increase EBAP to counterbalance the intrinsic beep. Now, in this scenario, I would like to explain one point here. Bear in mind that an external beep does not remove the trapped gas and it does not eliminate an auto beep, but rather it just counterbalances the inspiratory threshold load that is imposed by the auto beep. How it does that? It does that by reducing the pressure gradient that the patient must overcome prior initiating sufficient trigger. And if that happens, then definitely this would lead to patient's improvement of the patient vent synchrony. طبعا the bottom line in here and the important point, we have to realize that EPAP has a rule that is beyond oxygenation. If it is dealt with wisely, it can improve patient's vent interaction actually. The remaining options were incorrect, as in option A, increase IPAP would improve the ventilation and the tidal volume, and that would definitely aggravate the asynchrony by worsening hyperinflation. A reduction of IO2 will, whether it is reduction of IO2 or increase in of IO2, this will not improve such issue and will not treat the underlying mechanism of such asynchrony. Giving sedation, yes, this would blunt the respiratory drive and would delay further recognition of deterioration and will not fix the underlying cause. So here's the last question for the first case. Despite optimization, our patient deteriorated and he became drowsy, still awake but drowsy, with weak efforts, with a reduction in respiratory rate as well, and also there was an evidence of worsening acidosis of the blood gas. So what is the next most appropriate step? Is it to continue on NIV and reassess after an hour? Further increase IBAP to improve ventilation? Proceed with endotracheal intubation? Or change to a better interface?
And now we have a poll option, so please feel free to vote in the poll. I think about 48%, or actually that's 82%, choose as the right answer, Dr. Zahra.
Perfect. So we're glad that most of them got it right. So basically, you definitely proceed with endotracheal intubation. The scenario states a clear failure of NIV therapy, and that is characterized by a decline in mental status, poor effort, worsening acidosis. And even if the blood gas was within an acceptable limit, our patient was unable to sustain such adequate ventilation despite optimization, despite support. So delaying intubation at this point would just worsen the outcome and would increase the mortality. And if you delayed it further and apply NIV, you'd see yourself running into a crash intubation or a code soon. So option A, continuing NIV as we stated, is unsafe. B, increase IPAP. Yes, this could correct the acidosis, but this does not reverse the clinical status or get your patient in a better shape. D, changing the mask. Actually, there was no interface issue noted to start off with. So do not delay intubation if it is needed, as long as the patient's clinical status has worsened, regardless of the black gas. So the second case is a 62 years old male with no known medical background history, presenting with acute dyspnea, fever, productive cough. Chest X-ray showed bilateral infiltration consistent with pneumonia. Vitals were significant for tachycardia, tachypnea, saturation of 85 while on maximum on a breather. Blood gas showed hypoxic respiratory failure. So NIV was attempted. Shortly after initiation, you've noticed that the patient is uncomfortable with visible mask leak and poor synchrony. The delivered tidal volumes were inconsistent throughout. So what is the best next step to take? Is it increase IPAP to improve better tidal volume? B, change the interface to reduce the leak? C, reduce backup rate? D, administer sedation to improve tolerance. We'll give you a few seconds to think about it and
Can
make
you
your
go
choice.
back to the previous slide, just show us the settings that the patient was on? Thank you.
There you go.
So IPAP was 10 and EPAP was 5. Very nice. Let's move on to the next slide so you can see the options again. And I think about 68% have chosen option B.
Perfect. So this is the correct answer, to change the interface to improve the fit and reduce the leak. طبعا interface issues, as Dr. Muhammad stated, it's a common issue during NIV therapy. If that is noticed and corrected, the good thing about it is that correction such issue would lead to dramatic and immediate improvement. However, if that went unnoticed, this will lead to poor delivery of the pressure and so as the volume, and this would worsen the synchrony and would lead to air leak, and of course at the end this would lead to NIV failure therapy. The main important point in here is that if the mask is wrong, nothing else will work unless you make sure that the mask fits properly. So option A, increasing the pressure would just worsen the leak further. C, increasing the backup rate does not address such issue. Sedation, well, you might see that your patient is calm, but that does not address the leak again. So make sure that the mask fits properly. So after adjusting the mask, you've noticed that there are frequent auto-triggering. What is the most appropriate ventilator adjustment that can be taken to overcome such asynchrony? Is it to increase the trigger sensitivity, decrease trigger sensitivity, increase IPAP, increase EPAP? Let's pause for a few seconds.
It's kind of split here, but about 52% has chosen option B, decreased trigger sensitivity.
Excellent. So most of the audience were correct. High trigger sensitivity is actually one of the common cause of auto-triggering during NIV therapy. It's actually the major contributor. However, there are other factors that could contribute to such issue, which is circuit leak, water condensation within the tubing, and even cardiac oscillation that can be falsely interpreted as patient effort and hence initiating triggers. So, one way to overcome such issue is to think about it systematically. So, you work your way out from the patient, mask, tubes to the vent. So, check for mask leak. That's number one. Number two would be checking for the circuit, if there's any leak or damage. And if there is any condensation, that should be drained as well within the tubing. And then finally, if all of those stuff were corrected, but still there is auto-triggering, then the trigger sensitivity has to be changed into a less sensitive to reduce the trigger sensitivity, basically. Or alternatively, you could increase the threshold of the trigger. By doing so, you'd be able to prevent false triggering. So option A, increased trigger would definitely worsen auto-triggering, as we just stated. C and D, adjusting IPAP or EPAP does not address such trigger asynchrony. So here's my references. Thanks for listening, and be happy to take any questions if there are any.
Perfect. Thank you so much, Dr. Zahra, for this very nice interactive case-based discussion. And now we'll open the session for question and answers with Dr. Hisham Faisal and Dr. Yasser Tolba.
Okay, thank you, everyone. Dr. Muhammad, just a quick question. How long are you going to leave the patient on BiPAP or NIV, like 24/7, or do you give breaks? And during these breaks, how you support your patient?
طبعا thank you so much. طبعا يعني if the question is the maximum time for continuous BiPAP يعني without breaks, يعني ما في mixed maximum time. Obviously احنا we like to give people breaks every 4 to 6 hours. The decision is mostly based on patient trajectory rather than the clock. يعني most importantly, you need to assess your patient at 1 and 2 hours. يعني patients who show improvement in RR, work of breathing, pH, CO2, mental status, oxygenation. يعني such patient, yes, I can give them a break and then resume BiPAP as needed. And such patients, مثلا, for example, COPDers, they can go on BiPAP for 2-3 days depending on their trajectory. يعني عرفت كيف؟ يعني أهم شيء the trend. يعني if the patient seems to be improving and looking comfortable on the BiPAP, then yes, I can continue the BiPAP for 2-3 days, but obviously with breaks. يعني 4 to 6 hours and then 4 to 6 hours, not 46 hours. And then break for a couple of hours, up to 4 hours maybe, depending on patient comfort. طبعا putting someone on BiPAP continuously for 24 hours without any breaks could be a problem. It means the patient does not tolerate mask off, يعني zero time tolerated. So such patients usually, it means they're not improving. يعني such patients generally will display other signs that they're not improving. For example, they will display signs of high work of breathing, distress, despite an oxygenation looks normal, even the ABG might look acceptable, but then the patient's distress and work of breathing is worse, or not improving. This can be easily covered with a blanket, for example, and then you don't see your patient using accessory muscles or sucking in his abdomen. So يعني such patients, 24 hours continuous, always look for signs of work of breathing and distress. Such patients would generally require to be intubated.
Yeah, very good. No, I'm talking about patient who's not worsening. I'm just talking about NIV as a treatment. Would you give interruption for people to eat, and how long you to go to give it? And do you have a protocol like 4-2, 4-1, for half an hour. You need to have a rule in order for your RT and nurses to follow. Do you do this in your hospital?
جميل. Yes, we do. طبعا every hospital has its own local protocol. Now, this is not clearly يعني agreed upon between experts. So in general, what we do is 4 hours of BiPAP. If the patient is improving, stable on the BiPAP, then we give them a mask break for between 2 and 4 hours, depending on tolerance. So it's 4 and 2. If the patient is tolerating, then 4 and 4. And then we increase the mask off periods زي ما قلنا as time goes by and the patient seems to be improving.
Thank you.
Dr. Muhammad, I believe you have a very large experience in COVID. There is one question about those patients with COVID, and it is noticed that they have a huge tidal volume up to 1 liter with little IBAP. And what is the explanation, management, and especially those patients had higher rates of pneumothorax and pneumodiastole. How would you?
Jamil, this is an excellent question. Actually, we learned a lot during the COVID season, and I'm sure everyone who worked during COVID has seen this. يعني مثلا you look at the patient and you apply BiPAP, his saturation was 60% on room air. You apply BiPAP and their saturation is 94, 95%. And you're immediately happy because this was type 1 respiratory failure. CO2 was originally normal anyway. And the patient has improved the type 1 respiratory failure. But there's something you're missing. The patient is generating 1,000 ml per tidal volume. Now, is this machine generated or patient generated? In such a patient who is breathing negative pressure and he's doing his own effort, it's almost always patient generated. Hence, the patient's self-inflicted lung injury. يعني الفكرة إنه if the patient is generating 1,000 ml in tidal volume, it means the patient is generating so much negative pressure that we're not measuring. We cannot measure. We have no way of measuring unless you insert an esophageal probe. So we're not measuring, we're just looking at the NIV pressure, and we think the driving pressure on NIV is only 10 centimeters of water, so we're not causing any lung injury, but then the patient is generating negative 50 of يعني extra pleural pressure, plus the 10 that you're giving, that's negative 60 in total, which will bound to cause lung injury. So most of these patients, they might be complicated or worsen because of the patient's self-inflicted lung injury rather than the tidal volume itself. Obviously, the tidal volume is injurious because we know low tidal volume ventilation, ARDS, is proven efficacious in reducing mortality and complications. But now this is patient-driven. يعني such patients, COVID or otherwise, any ARDS patient, they have a high respiratory drive and they tend to suck air more vigorously. So if a patient is doing this, I would generally intubate.
One of the attendees is asking, do you use target tidal volume to adjust for IPAP? And what tidal volume is ideal? Is it 6 or 8 mil per kg? And if the target tidal volume is 450 and the patient only generates less than that, like 300, with a good fitting mask, would you increase the IPAP?
Jamil, so do I use a target tidal volume of 6 to 8 ml per kilo? No, not routinely. So basically this target tidal volume has been validated in the ARSNet protocol for invasive mechanical ventilation of ARDS patients. So it hasn't been validated on non-invasive ventilation per se. Now, unlike invasive ARDS, invasive يعني mechanical ventilation on ARDS, the NIV tidal volume is heavily influenced by the patient effort. زين يعني مثلا in severe ARDS you generally sedate and maybe you even give them muscle relaxants, but at least you sedate them deeply so that they can tolerate the low tidal volume ventilation, صح ولا لا? But in non-invasive ventilation they are awake, so the tidal volume is heavily influenced by the patient effort and obviously by the mask leak as well. يعني if there is a higher leak, then there is compensation with apparent larger tidal volume. So should I increase IPAP because the tidal volume is 300 as opposed to 450? No, not the sole reason. I would not. If the patient is improving in terms of RR, CO2, pH, oxygenation, patient looks comfortable, then a tidal volume of 300 is very acceptable. If the patient is not improving, a tidal volume of 300, and the patient is not improving in any of the above parameters, then yes, I would probably increase IPAP. So my driving decision is not because the tidal volume is 300, it's because the patient is distressed, RR, CO2, oxygenation. Now, another thing, it's probably the flip side. Before the flip side, I think I want to elaborate. If the patient is generating very low tidal volume, we're not talking about 6 to 8 ml per kilo. I'm talking about مثلا 150 cc in total, or 200 cc in total. That's a very low tidal volume. You're just ventilating the dead space, صح? The patient's own internal dead space. So such a patient, yes, I would increase IPAP because I'm not ventilating the alveoli at all. Then on the flip side, I would care more about the large tidal volume. السؤال اللي قبل شوية عن ال ARDS patients, because they tend to have a high respiratory drive. So pay attention to those patients in terms of preventing PCLE.
Another question from Dr. Muhammad Hashala. He said, in case of pneumonia, with CO2 is not the issue, is the main hypoxia. He said, I would use high flow nasal oxygen over BiPAP. Do you agree?
So if the patient is not distressed, ما في work of breathing, and it's just hypoxemic failure without high work of breathing, then I totally agree. High flow nasal cannula is much more comfortable to patients. They tolerate it very well. It's humidified, it's warm, it does not push air over the patient. It does not involve a tight strap. It's not that tight on the patient. Patients can talk, they can eat on it. So yes, it is much more comfortable than with much less contraindications than BiPAP. ولكن if the patient has work of breathing, the patient has using accessory muscles, difficulty taking a breath, then probably high flow nasal cannula will not cut it.
We have one question to Dr. Zahra. She touched in her questions, and probably it was causing some confusion. How to overcome the auto beep during NIV, increase EBAP or increase IBAP. Maybe Dr. Zahra would like to answer this.
So increasing the EBAP, applying the external beep would act as a splint. It would just reduce the pressure gradient, and hence the patient would be able to generate negative pressure to overcome the load that is generated by the intrinsic beep. Applying IBAP will not help in such asynchrony.
This concept can sometimes be difficult to understand. So imagine somebody is already weak. These patients have already, this patient are already trying to take a breath, and this patient already have intrinsic beep. So when you try to take your breath, you have to overcome your own beep. For example, if you have already intrinsic beep, because these are patients who have COPD, and they have they are difficult to get their air out because of the constricted bronchioles and bronchi. So they have accumulated a beep, and their alveoli is difficult to exhale. So what happened when, as Dr. Zahra saying, when you apply external beep, you negate that beep. So you open up this, so for example, instead of the patient trying to overcome this 5 of beep to get to 0, then add the inspiratory effort. If you give this 5, if you give the patient this extra 5 of beep of extrinsic beep, this will negate the negative 5. You got me? So 5 negate the 5, then the patient only need to give the 2 centimeter of water to get the breath in. I don't know if this will explain it a bit more. Do you agree, Dr. Zahra?
Yeah, it alleviates the pressure gradient. Exactly. So it's the
Exactly.
pressure gradient that the patient would be able to overcome it easier and hence generating the negative pressure.
Exactly. Excellent.
I guess we will end by now. We are already exceeded our time. Thank you very much for both speaker, Dr. Mohammed Abdurrab Nabi, Dr. Zahra Dawood. Many thanks for Dr. Yasser Tulba for moderating this session with me. And thank you very much.
Thank you, Dr. Hisham. And by tomorrow, you should all receive the YouTube link of the recorded webinar. By next week, all the attendees should get a certificate of attendance. Again, if you would like to join our fellowship that's going to start next Monday, please go ahead. If you have any questions or inquiries, please feel free to contact us. And we'll see you again in our next webinar. Dr. Ayush Bandi from India. He's going to be our guest speaker, and Dr. Shireen is going to give a case-based discussion. So please stay tuned for our July 6th webinar. Have a good rest of your day, good afternoon, good evening. Bye.